lugares para no interrumpir la actividad. En nombre de la Universidad Técnica Federico Santa María y su Departamento de Ingeniería Comercial, les damos la más cordial bienvenida a esta primera Conferencia Internacional sobre Management Analytics and Data Science. Saludamos a la autoridad que nos acompaña esta mañana, el director del Departamento de Ingeniería Comercial, el doctor Pablo Isla. También saludamos a los académicos, profesores, estudiantes, funcionarios e invitados que nos acompañan esta mañana. Alineados con la visión de nuestro fundador, don Federico Santa María en crear y difundir nuevo conocimiento, además de formar integralmente a profesionales idóneos en el ámbito científico y tecnológico para liderar el desarrollo del país y la humanidad, es que el Departamento de Ingeniería Comercial de la Universidad de Santa María genera este tipo de instancias académicas. Precisamente el día de hoy conoceremos en profundidad sobre el Management Analytics and Data Science, disciplina que combina conocimientos de análisis de datos con dirección y gestión de empresas. Y para ello contaremos con la participación de distinguidos exponentes académicos y líderes de la industria, quienes abordarán estas temáticas. Para dar inicio a la actividad, invito al director del Departamento de Ingeniería Comercial, el doctor Pablo Isla, a dar unas palabras de bienvenida.
Buenos días, quería darle la bienvenida a esta conferencia y a nombre del Departamento de Ingeniería Comercial, también contarles nosotros somos un departamento de ingeniería comercial un poco atípico, somos un departamento de administración de una gran escuela de ingeniería como es la Universidad de Federico Santa María. Entonces, en ese sentido, no queremos parecernos a otras escuelas que son escuelas de negocio. Generalmente nosotros queremos ser fieles a nuestra mandato, que es parte de una escuela de ingeniería. En ese sentido, nosotros nos interesa, hemos definido como uno de nuestros ejes la tecnología, el tema de metodología y la tecnología al servicio de las organizaciones, y el otro eje es emprendimiento. Esta universidad que tiene muchos emprendedores y mucho emprendimiento, y queremos ser parte de un vehículo para que el emprendimiento se manifieste dentro de la universidad con nuestro aporte. Y el otro gran tema, como les decía, es la ciencia de datos, el tema de la tecnología aplicada al mundo de los negocios y del mundo de la gestión. Uno de los padres fundadores de la administración, Henri Fayol, en Francia, que hoy día sería un ingeniero químico, él inicia las escuelas de administración, que en su momento se llamaron las escuelas de comercio, un poco con este tema de la necesidad de contar con información, de trabajar con información para poder tener la casa en orden. Es decir, un lugar para cada cosa y cada cosa en su lugar. Y con él un poco se inicia la historia de las escuelas de negocio, su inicio, escuelas de comercio. Entonces nosotros eso es lo que nos interesa, estar siempre muy cerca de la tecnología que necesitan las empresas, muy cerca del emprendimiento. Entonces, en este sentido, esta conferencia es un punto bastante importante para nosotros, porque junta esos puntos, y ahí aprovecho de agradecer a los organizadores, a la profesora Joseph, que la verdad que ha organizado toda esta conferencia. Así que, Joseph, muchas gracias. Joseph, además de ser doctora en economía, es matemática pura. Entonces ahí se pueden dar cuenta del tipo de escuela de ingeniería comercial que estamos construyendo. Muchas gracias, Joseph. Y junto con Joseph, también agradecer a la empresa, a ti, empresa de Salón, una empresa de Salón, que está trabajando fuertemente con nosotros. Estamos desarrollando el primer índice de madurez de inteligencia artificial. Seguramente ahí se les va a pedir que pueden contestar una encuesta, que estamos trabajando fuertemente con ellos desde hace ya un tiempo, y también es una buena muestra de cómo podemos asentar estos dos mundos, el mundo de la tecnología, el mundo de la tecnología, con el mundo del emprendimiento. Así como tienen, hay otras empresas que han nacido de esta universidad, que pueden nacer de esta universidad y en ese sentido a liderar el camino. Así que muchas gracias por facilitar. Así que bueno, quería solamente inaugurar la jornada de hoy y que tengamos una buena continuación. El tema es el punto inicial. Agradezco también a las personas que han venido de otras instituciones. Creo que no solamente tenemos alumnos y concurrencias de la universidad, también tenemos personal de la Armada, algunas caras de la Armada. Ustedes saben que Valparaíso básicamente es la Santa María y la Armada, básicamente. Pero muy contento de ustedes de acá y de otras instituciones también que nos visitan. Así que después de inaugurar la sesión, y se da un proyecto para todos. Muchas gracias.
Muchas gracias, director. Ahora comenzaremos con la charla de la profesora Margaret Brandeau. La profesora Brandeau es catedrática de Ingeniería y catedrática de Política Sanitaria en la Universidad de Stanford. Sus investigaciones se han centrado en el desarrollo de modelos matemáticos y económicos aplicados a las decisiones de política sanitaria. El día de hoy nos presentará la charla magistral titulada Advanced Analytics for Better Health and a Better World. It's a great honor to welcome you in our university. Please join us on the stage to begin your presentation.
Muchas gracias por invitarme. Es un gran placer estar aquí, pero yo voy a dar mi charla en inglés porque no hablo bastante en español. Muy bien. So thank you very much for inviting me. It's really a pleasure to be here and to meet all of you. Today I'm going to talk about advanced analytics for better health and a better world. My talk today has three themes as indicated by Okay, muy bien. My talk today has three themes as indicated by my three pictures. First is data, how we can exploit newly available data. The second is machine learning and artificial intelligence. So in our world today, we have lots and lots of data. How can we use it? And the third is broader problems. So my talk is focused on health, but also a better world. So not only how we can use data and machine learning to improve health, but maybe how we can extend these ideas to think about broader social and environmental problems. So I'm going to give examples of decision-making in 4 different areas. Improving patient care with artificial intelligence and data analytics, responding to communicable diseases, thinking about drug abuse, and thinking about the health impacts of climate change. So a rather broad set of problems that we've worked on. But first I want to talk a little bit about the current state of global health and the current frontiers in health care. So in global health, right, in the last few 100 years, we've seen remarkable increases in life expectancy in our world. I think in the last 250 years, life expectancy went from about 30 to 35 years to now being 60 to 80 years. So dramatic increases in life expectancy, which is good. Along with that, we've seen increases people live longer, so now they have heart disease and diabetes and high blood pressure. So changes in the diseases we see. In addition, because of increased urbanization, increased travel, we've seen the rise of pandemics. We all are still, I think, reeling from the COVID pandemic. Other changes in global health, right? We have climate change, which affects many different things, not just us feeling hot or cold. I think another trend we've seen in global health is that there are increasing health inequities. Some people within countries and within the globe. Some people have good health and get good health care. Some people do not, and the inequities, the disparities have increased. And finally, I think the last thing in global health, we're starting to realize that the state of a person's mental health has a lot to do with the state of their physical health. We saw a lot of this in COVID, right? When people were, and all of us, I think we were locked at home. That was very difficult. And our children were locked at home. So what about new frontiers in healthcare? So talk about how health is changing. Well, one big thing, and of course this is one of the themes of this conference, we have more data. We have digital health technologies. So we have mobile health apps, we have wearable devices, we have lots and lots of digital technologies that are enabling health. And of course, to exploit this data, we have AI and machine learning. And of course, that has the potential to revolutionize healthcare, hopefully in a good way. Precision medicine. So we have a lot of data, and now we can think about what is the best treatment for you. So we can have best, tailored prevention, diagnosis, treatment, based on many factors about a person. Another interesting thing, robotics. This is actually a very interesting area for data science and healthcare. For example, people who have a brain tumor, the way the radiology is now organized is algorithms are used to figure out which rays should be pointed at the brain in which intensity and which direction, so you kill the tumor and not the patient. Of course, also we have robotic surgery. That's a picture of the Da Vinci robot doing surgery. My friend who's a neurosurgeon told me, yes, we use this because it doesn't shake like your hand shakes. It's very precise. I think other things in healthcare, as I mentioned about mental health, we're understanding that behavior is very important to health. And so understanding the effects of behavior on health. And finally, social determinants of health. So people who are homeless, that's a picture of a homeless person. Sad to say, it is probably in my home city of San Francisco, right? People who are homeless have bad health and bad health outcomes. So these are some of the new frontiers in healthcare that I see happening on the horizon. So what I want to talk about is projects we've done in 4 different areas that to different extent focus on these themes and use data and data analytics. So first is improving patient care. The second is controlling communicable disease. The third is responding to the US opioid crisis. And the last one is thinking about a specific aspect of climate change and human health. So in each of these areas, I'm going to talk about projects that we have done that use AI, machine learning, or just data analytics. So the first area is informing patient care with improving patient care with AI and data analytics. And the first project I want to talk about is predicting and improving medication adherence. So when your doctor prescribed something to you, you probably go to the pharmacy and pick up the prescription, but not everyone does. So the question is, what can we do to improve medication adherence? I found this interesting quote from the World Health Organization that says, increasing medication adherence may have a far greater impact on population health than any improvement in specific medical treatment. In other words, if medication is prescribed, it's probably better to take it than to face the consequences of not taking it. It turns out medication non-adherence, so not taking your medication, is expensive. It's estimated in the United States that about 20 to 30% of medications are not filled. Maybe 125,000 deaths annually because people don't take their medication, they become sick, they have to be hospitalized, and maybe about $100 billion in annual costs, so very expensive. So this is the problem. How can we support physicians in getting patients to fill their prescriptions? So our idea was to use data to develop a personalized intervention aimed at improving adherence. And so we used machine learning and a decision model. So let me tell you about that. So we worked with some colleagues in Israel who have data from Maccabi Healthcare Services. Maccabi is the second largest health maintenance organization in Israel. It serves about 25% of the population, or 2 million users. So they gave us data for 10 years from their healthcare services. So we're talking about a lot of data. They gave us data for 250,000 patients. Oh, and we were looking at, in this case, for our model, at antibiotic prescriptions. You could look at other things, but this analysis was looking at antibiotics. So 250,000 patients who were in Maccabi Health Services for all 10 years. They collectively had 1.8 million prescriptions done by 6,000 physicians for 30 different antibiotics. Okay, so that's our data set. And it turned out that in this data set, 82% of the prescriptions were purchased. So that means 18% were not purchased. So our idea was we want to predict when the patient is here in the office, are they going to fill this prescription, or do we need to spend some extra time and money to tell them about the importance of filling the prescription? So we used a machine learning model. So we have all this information from the patient's electronic health record. We're going to use machine learning to say, what is the chance of this person purchasing this antibiotic that we're now prescribing? So I'm showing you here a curve of showing the false positive rate and the true positive rate. We looked at 3 different models for prediction. Now, here, the dotted line is a random guess. That's the diagonal line in this curve, and it says, I really don't know. Of course, we can do better. Then we thought, well, why don't we just look at the patient's previous behavior? Did they purchase or not? Not that good. So that's our second one, that blue one. Then we thought, maybe we look at their previous behavior and socio factors about them. Are you man or woman? How old are you? So just which part of the country do you live in? Is it poor or rich? Things like that. So we got a little better. But then we added in the information from the electronic medical record, and that was the best because we want to get as high up here as we can. So the best prediction model, in this case, is a random forest model. The area under the curve was 0.684, and it had 82% accuracy in detecting individuals who had less than 50% chance of purchasing. So it was a pretty reasonable prediction model. So we have a prediction model, but now we have to turn this into a decision model. Like, when should we spend extra time with this patient? So my model can tell you the chance of them purchasing this antibiotic, but now I need to know, should I spend extra time and money talking to this patient? So we made a decision model that would recommend intervention if the chance of adhering is below a threshold. So basically, we're balancing the costs and the benefits. It costs me money to spend time with the patient saying you should really take this antibiotic, but if they don't fill it, it costs money when they have to go to the hospital and come back to our HMO, etc. So you balance those two. So that's our decision model. So So using the data from Maccabi, we found out that, in fact, using this, you can save money. You can increase the number of prescriptions filled and generate savings. In this case, for the particular data set, we could have saved about 6.4% in annual cost and fill about 4% more prescriptions. So this is an example, and we published this in a journal called Healthcare Management Science. And my graduate students told me I had to be very modern and put a QR code for the paper. So I'm very modern, just so you know. Anyway, so, but I think this is a nice example of real-time intervention enabled by AI and machine learning. The second project that we are doing that involves AI and machine learning is about remote monitoring of diabetes patients. So I work at Stanford University. We have an adult hospital and we have a children's hospital. We have two different hospitals. And we were working with Lucille Packard Children's Hospital. That's our children's hospital. It's a pretty good sized hospital. We have like 500 beds. We treat a lot of patients. So at our hospital, we treat approximately 1,000 pediatric diabetes patients. And these patients have continuous glucose monitors. So here's an example of a child with a continuous glucose monitor. She has this small device here that monitors the glucose level in her blood. In other words, it tells how well the diabetes is being controlled. Then this is fed up into a device, which then is fed up to our clinic. So real time for 1,000 patients, we have their continuous glucose levels all day, every day. And the idea with diabetes is you want to keep the glucose level within ranges. You know, I'm sure you've all had the experience of having a really big meal and then you feel sleepy, right? Or you're hungry and you feel weak, right? Your glucose levels change all day long. It's natural. But for people with diabetes, we want to keep those levels within a range. We want to keep it, you know, it can go up and down, but it should stay within a range. So we're getting all this data, and we need to know what to do. These patients are just out there in the community with their families and their children. So our idea was we would use this data to monitor our patients, to assess their health, and figure out which ones to follow up. So as I hope I've emphasized, with 1,000 patients in continuous data, there is no way you can know how and monitor all that data. So this is a perfect example for AI and machine learning. So one of our grad students worked on machine learning to prioritize patients based on their likelihood that they would benefit from intervention. And intervention could be a text to the parents, a phone call, or even saying, come into the clinic, you need to see the doctor. Okay, so those are the interventions. And so the way the machine learning algorithm worked is he looked at the glucose time and range. I mentioned that you want to keep the glucose level within an appropriate range. So you see how much it is in the range for the patient. Is their diabetes controlled, or is it getting too high, too low glucose? And then you think about what is the potential improvement from contact. So not everyone is going to improve, and so you need to think about what's the potential there. So that is how the algorithm works. And just to give you a picture, so the idea here is that this is, let me see, try not to turn this off. This is the range we want, the target range for glucose, and here's time. And so, and here's someone's glucose level. Just made that, you know, over time it's getting higher. If we have periodic monitoring, in this case, it looks like I've got it happening once a month, you could see the patient might get out of control. Our new system is continuous monitoring. So we can always know what's happening with the patient, and we can keep the glucose within the appropriate range. This approach is described in this article that my colleagues had in this journal. So we have implemented this at our diabetes clinic. And what happened? So we initially implemented it with 225 patients more patients now, but when we started, 225 patients. And what we found out is that we spent 60% less time reviewing data and contacting patients. Because remember, someone doesn't have to do it manually now. So it went from about 3 minutes, 3.2 minutes per patient per week to 1.3 minutes. So that means, in essence, we have a significant increase in clinic capacity. We spend less time with the patients. But of course, it's not about spending less time with patients. It's about improving health, right? So it turns out that the patients that we did review remotely, they actually increased their time that their glucose is in range by 8.8%. So not only did we save time and we're more efficient, we're actually improving health by using this machine learning. And so this system has been going on at our hospital for 2 years, and now we're going to expand the system to 1,000 patients. And for the first 225, the work is described in this article in the journal, Pediatric Diabetes. But I think at a higher level, this is a nice example of how you can have patients who have wearables. The data from the wearables is fed up to a platform or an app. Then we can have visualizations, decision support, machine learning, etc., which then enables our care team to provide personalized treatment. So I think this is a nice example of how we could use such an approach for other types of wearables and other types of chronic diseases such as hypertension, chronic obstructive pulmonary diseases, etc. So these are 2 examples of projects we've done on patient care. Now I want to talk about a couple of projects we've done on controlling communicable diseases. So I mentioned COVID-19, and I feel like you can't give a talk about communicable diseases without talking about COVID-19. I know we want to put it behind us, but we'll just talk about it for a minute. Right, when we had COVID-19, we know that this disease is spread from person to person. So many countries had mobility restrictions. Here's a picture from somewhere in the US, stay home, essential travel only. And so we had lots of lockdowns of different intensity in different places. But I think when we want to think about restrictions of this, we really need to know where is the outbreak. We saw in COVID, there were big outbreaks in some places, and then those died, and then another outbreak elsewhere. So we would like to be able to predict outbreaks. So the goal of this study, we worked with some colleagues in Israel who had a lot of data, which I will talk about in a minute, was to be able to project the severity of COVID in different districts of Israel. And then we use cell phone mobility data as part of this, so determine how useful that was. So our approach, we use machine learning to predict outbreaks, and we use cell phone mobility data and other data. So let me tell you about the data. So we had lots and lots of data. We had data for 3 million cell phone users in Israel from February 1st to November 30th, 2020, and we had the ping from their cell phone for every 15 minutes. So massive amounts of data. This data, obviously we had to do a lot of data processing, had to make sure it was completely anonymous, etc. And I think we actually aggregated it by day, so where you went each day as opposed to where you went every 15 minutes. But lots and lots of data about where each of these 3 million cell phones went all day long. We also had health data, right? We had data such as how many COVID cases there are, how many tests, how many recoveries, etc. And we had lots of demographic data as well. So I think I just want to emphasize that there was a lot of data. And my students spent at least a year trying to get this organized and cleaned up. So, but this is good. Data is good, right? That's one of the themes of my talk, that we have a lot of data. Let's use it. The students might tell you a different story about how good a lot of data is, because it was a lot of work. So the way our model worked is we did some feature engineering with the data. So we took the health data, such as the number of COVID cases, and we made it lag by 1 day, 3 days, or 6 days. Then we took the mobility data and we thought, well, maybe, we did this for 14 regions of Israel. We took the country, you could think of almost like states. The country has 14 regions. And we made what we called a pressure score, which is travel into a region. So like a city like Tel Aviv, people come from elsewhere, or maybe like here, Santiago, people like Jocelyn, she comes from outside Santiago to go to work. Your cell phone knows that. Anyway, so we made a pressure score of traveling into a region and then an internal movement score. So that's how we use the cell phone data. So then we had a prediction model, which I'll talk about in a minute, which we used to predict over the next 7 days some average incidence, and that's new cases, and the test positivity rate. But then we were working with the Israeli Ministry of Health. They don't care if there's like 2,000 cases. They want to know, is it a severe outbreak or not? And so we had a decision rule that would classify the severity of the outbreak. Okay? So for the prediction model, we tried, actually my grad student tried lots of machine learning. It turned out the best model was linear regression. Who knew? It worked out with decay, so that you count more recent data more strongly, and a half-life of 2 weeks. And it turns out that it did not, our prediction model did not use the demographic data. It only used the health data, lagged, and the internal movement score. Okay, it did use the cell phone data, but internal movement, just how much you're traveling around. Okay, so linear regression. So here's an example of prediction. So I mentioned there were 14 regions of Israel. I have no idea why it's called District 24, because there are not 24 districts. But so here's a graph. The x-axis is time, and this is showing the past 7-day actual cases per 100,000 people. So we've kind of aggregated it into 7 days. So, here's what's happening in this district, and then at this point, we see a pretty big outbreak, and then it goes down, and then it goes up. Now, I mentioned we were going to do a prediction model. So we had all this data, and we're going to predict forward. So now what I'm showing, the dashed line here is the next 7 days prediction, and the shaded green area is a confidence interval. Clearly, as you go further in the future, you're less confident. But we have a rolling horizon model where we're going to do predictions. Now, one thing I want to mention here that's interesting, and I hope you can see it in the graph, is that here, cases were going down, actual cases. But then, even though they were going down, our model accurately predicted that it was going to go up. Well, how do we know this? Cell phone mobility data, right? Even though the cases are going down, our model's like, oh, people are moving. And so it could actually predict. So we got pretty good predictions. And another thing I want to mention is we were working with the Ministry of Health, and they had different tiers, like for severity. And so we could tell them for the predictions, will it be low, medium, moderate, severe, or super severe? We could tell them how severe the outbreak would be. The first thing we saw is that when we tested our models, the cell phone data actually improved the prediction accuracy. But more than that, our model had high magnitude accuracy. And what I mean by that is here I'm showing like the 5 ways they think about how severe the outbreak is. Is it minimal, moderate, substantial, widespread, or critical? And our model was very good at telling you for each region which kind of tier the outbreak would be in. And that's really what the Ministry of Health wanted to know. It's like, should we be locking down? Or what level of restriction should we have? How serious will it be? Of course, if we can accurately predict, as I've kind of indicated, we know more about lockdown. We also would know, oh, you might need to have more hospital beds here. You might need to have more medical staff. You could better allocate resources. And I think this kind of model, although I talked about COVID, we can certainly use this to predict outbreaks of other communicable diseases like influenza, measles, SARS, lots of other things. So we published this article in the journal PLOS ONE. So this is one example of a model we did on thinking about communicable diseases and using data. The second project, which is hot off the presses because I believe it was just published yesterday, is about using smartwatch data to control epidemics. This is also a study I've been doing in collaboration with some colleagues in Israel. We have a prospective observational study of 5,000 participants in Israel. Each of these people was given, this is not the correct picture, was given a Garmin smartwatch, a Vivo 4 smartwatch. So we gave everyone a smartwatch. And what they have to do in this study to get a free smartwatch, and all they have to do is fill in a daily questionnaire. And they're all members of Maccabi Health Services. So we have their electronic medical record data. So these people, time is passing, they're getting the COVID vaccine, they're maybe getting the flu, whatever's happening in their life. And every day, their smartwatch just finds out things about them. And they fill in a daily questionnaire. I'm sick, I'm not sick, I feel happy, I don't feel happy. Our colleagues made up a dedicated questionnaire. And I mentioned we have electronic medical record data. So we have 3 large-scale sources of data for these 5,000 people. Electronic medical record, smartwatch, basically continuous smartwatch data, essentially, and information from the dedicated mobile app. So in this particular, we've done several things with this data, but in this particular study I'm going to talk about, we looked at participants who had, over the course of the 2 years, had become infected with COVID-19 or influenza or group A streptococcus. So they've gotten one of these infections, and we know this from their electronic medical record. And what we want to know is, for the patients who got these different diseases, when can the smartwatches detect the infection? When do the patients report symptoms? And when do patients go and get tested? So we want to know about, are the smartwatches going to help us understand the patient's infection? So here's an example of one of our findings. So what I'm showing you here is 3 graphs. The first row is for patients with influenza. The second row is for patients with COVID-19. And the third row is for those patients who got group A streptococcus infection. And now I've got 3 dots. So the first dot is, so let's focus on influenza. The first dot is when the smartwatch detects that there's something going on. So it turns out the smartwatch can tell your heart rate, can tell your heart rate variability, can tell other things too. So we use those 2 metrics, heart rate and heart rate variability. And we use a control chart approach for those of you familiar with like industrial control process. We use a control process approach to figure out when the heart rate or heart rate variability exceeded the control limits. In other words, something was happening. So it turns out that for influenza, and then the next dot is when the patient reported symptoms, right? Because if they're like, I've got a fever, I have a sore throat. And then the next dot is when the patient has gotten testing, okay? So the first thing we see is that, like for influenza, the smartwatch detected that you were sick approximately 2.5 days before you knew you were sick. For COVID-19, it was about maybe 1 day before you knew you were sick. And for group A streptococcus, it looked like it's about 3 days, okay? So that's the first thing to notice, is that the smartwatch can detect infection that you don't even know about. And wouldn't that be a good thing? Because if you're sick, like everyone knows, if you have COVID and you don't know it, you're just making other people sick. So, and similarly for influenza and group A strength. So if we can know early, that can really help. And then the other thing I'm showing in this picture is the mean daily steps that people took and the mean number of contacts they reported having. So basically, people did take somewhat fewer steps when they became sick. And once they, and until they got tested, they had slightly fewer contacts. But really, the main changes in behavior often came after the development of symptoms or is when they really changed. So that gives us thoughts about how they're spreading the infection, although this project was not about spreading infection. So some of the conclusions from this study, so I mentioned that the smartwatches could detect infection before the patients noticed they had symptoms. So it was 39 hours for influenza, 53 hours for COVID, 38 hours for group A streptococcus. That's the delay between symptom onset and testing, and the smartwatches detected the anomaly significantly well before. And so the conclusions of our study are that smartwatches have great potential to detect infection early. And then if we can do that, then we can have much better public health response. And as I mentioned, this article just appeared in Lancet Regional Health Europe, I think, today. So anyway, so that's the second area. The last two areas I want to talk about are sort of verging more into the social aspects of health. I don't know if this is the case in Chile, but in the United States, we have a very significant opioid crisis. We have probably 2.5 million people in the U.S. who have opioid use disorder, and probably 80,000 deaths per year from opioid overdose, and that's only increasing with fentanyl. So it's a very significant problem, a significant cause of morbidity, mortality, lost productivity, and criminal costs, right? People who are drug addicts tend to commit crimes. So I was on a commission called the Lancet Opioid Commission for the North American opioid crisis. And one of the things that we decided we would do is do some modeling. Instead of just having good recommendations about change laws, have more treatment, maybe we could do some modeling. So we decided to model the effectiveness of different policies for controlling the opioid epidemic. And to do this, we used a simulation model. It turned out, so now I'm moving from complex analytics to Excel spreadsheet model, but still useful and interesting. So we had a model of the U.S. adult population where we thought about who's got pain, who's got a prescription, who is using opioids, and who has an addiction to opioids, which we simulated this model. And we thought about different prevention and treatment interventions, and we thought about quality-adjusted life years. That's like life years, but what is the quality? And overdose deaths. So I'll just briefly show you what our model was. We had people who don't have any opioid use, and they may or may not have pain. We have people who have some pain who get opioid prescriptions. It may be acute or chronic pain. People can stop having prescriptions, stop having pain, etc. And some people who are taking these opioid pills become addicted, as indicated by my red compartments. And so, and then what we've seen in the U.S. is if you can't get a prescription, there's diverted pills. It was actually rather ironic when I was doing this study. My 90-year-old mother had to have some minor surgery, and she had some oxycodone pills, and the doctor made me take them away. And so the whole time I was doing this study, they were in the backseat of my car. I was thinking, oh, pill diversion, I'm leading to the problem. Anyway, so I did manage to dispose of them safely. Anyway, so people can be addicted to the pills, and then what we've also seen in the US, they can escalate to heroin very, very bad. People can get treatment, people can recover. So this is just a compartmental model. I think I'll skip some of the details here in the interest of time, but there were lots of cool things in the model. So we looked at a number of prevention programs. We looked at maybe we should just prescribe less. The reason we have the opioid crisis in the United States is because the Sackler family was very, very good at convincing doctors that we need opioid pills for pain. And don't worry, they're not addictive. So we reduced prescribing is one thing we could do. You can also reschedule where you don't give a 30-day supply, you give 7 days. For example, we can reformulate to make the drugs less addictive, although it turns out that's expensive. We can have prescription monitoring programs. When you go in, we do. If I, Margaret, am given a prescription, this gets put into a state database, and my doctor also gets put into the state database. And we can have safe disposal programs where you just toss safely. For prevention, for treatment programs, there's naloxone. That's an overdose rescue medication. Someone's overdosing, you spray this in their nose. We can have treatment. That's medication-assisted treatment, and we can also have psychosocial support. And finally, we can have things like legal exchange programs for drug users. So these are examples of policies that our government has thought of. So what did we find out? We found out that if you want to prevent deaths, the best thing to do is just get the overdose rescue medication out there. They're still drug addicts, but at least they're not dead. I think we also found out that prevention policies have mixed effects. So when you cut down on prescriptions, so this is a really good example of how advanced analytics is helpful because we have a dynamic model. When you cut down on prescriptions, people can't get their pills. Some turn to heroin, and because the heroin is also an opiate, and that's far more deadly. So you actually, in the short term, will have more deaths. But treatment policies are uniformly beneficial. So we concluded that really you should reduce prescribing, of course, but you better also expand treatment. And then the last thing I think where a model is useful is we show that no matter what you do, we're still going to have a significant problem for many years. So we published this in 2021. Okay, the last one I want to briefly talk about is climate change and mitigating the health impacts of climate change. So it turns out, and I didn't know this, that, well, I knew this. There's a thing called C3 plants. This, for those of you who remember biology from way back, C3 plants are plants who use a certain carbon fixation pathway. And 85% of plant species are C3 plants. We know that carbon dioxide concentrations are increasing in our atmosphere, but what I didn't know is that it is thought that as carbon dioxide increases in our atmosphere, the amount of zinc and iron in these staple crops like wheat, taro, rice, and peanuts is going to go down. And you may not know this, but certain parts of the world, people already have zinc and iron deficiency. I didn't know this. So this is a project we did with some climate scientists at Stanford and one of my grad students. And the basic idea is we want to model the health effects of these decreased zinc and iron concentrations. And we want to figure out, what could we do? What interventions could we do? So my grad student made this beautiful, and again, lots of data. He's not here to tell you about the pain, so we'll gloss over that. But a microsimulation model of 137 different countries in the world. And basically what he did is he looked at a demographically representative sample of 10,000 people in each country from 2015 to 2050, with and without the change. He assumed that the zinc and iron concentrations decreased linearly, and he modeled a representative diet for each country. So here's a picture showing projections of the cumulative burden expressed as disability-adjusted life years over the 35-year time horizon that he considered, 2015 to 2050. And so the cumulative health burden. And he did it for the 6 World Health Organization is showing is that for certain regions, so here we are, you can't quite say, but we're here in the region of the Americas, the impact won't be as severe as in other regions of the world, such as African region and Southeast Asia region. So this is going to, first of all, have a significant burden on health, but more than that, will increase health inequities. I mentioned that then we looked at some interventions, and we looked at several interventions. The Paris Agreement, where countries have agreed that they will keep global temperatures within 2 degrees centigrade of pre-industrial levels. That's not really working, but that was the agreement. And then you could also think, well, if there's not enough zinc and iron, should we take vitamins, right? So we can have supplementation programs. You could also think maybe if people become sick, we could just treat them. So what this graph is showing is for each of the different policies we considered, and for each of the 6 regions, how much of that cumulative health burden that I showed you can be reduced. And the main thing you should see from this picture is by far the best thing we can do is mitigate climate change. You know, certainly giving people zinc is helpful, giving people iron is helpful, but really by far the best thing we can do is climate mitigation. And I don't think I would have known this without a model. So we published this article in PLOS Medicine. So anyway. So these are examples of projects we've done that I think use data analytics, advanced analytics, and artificial intelligence and machine learning in different ways. So I would like to conclude with a few thoughts here. So I think that, as I hope I've highlighted in my talk, there are many opportunities for us to have impact. And as I've done research over time, my thinking has become broader. Like I used to solve really specific problems, like let's schedule the operating room, and now I'm thinking about things like, what about climate change? So I think we can apply our tools to many different problems. Many types of models can be useful. I think that's important to know. Although I didn't particularly highlight it when I was speaking, I think very often we have to collaborate with people from other disciplines. You know, as we know in our world with more data, more connectivity, more complex systems, the skills that we have using management science and advanced data analytics are really more important than ever. And another thing I want to highlight is all of our work is about informing good decisions. I mean, we like to have cool models, who doesn't? But really it's about how can I help people make better decisions. And finally, let me just return to my 3 themes. So I think, you know, I've talked about health, but in any area, we have massive new data that we can and should use to make better decisions. Again, I think probably preaching to the choir here, but machine learning and AI can really play a key role in many areas. And as I personally think, I think there are a lot of social and environmental problems where we can also apply our skills. I've talked about drug addiction and climate change, but there's lots of other things. In conclusion, I think that there are numerous important, practical, high-impact problems that we can work on using the tools of our profession, and I firmly believe this is the most important role for us in using our skills. So, thank you very much.
Thank you very much, Margaret, for that amazing presentation. We are really impressed with everything you have done to help people using advanced analytics.
She's my agent.
So I agree with you. It was a very nice talk. You really made like concrete examples of how this could be applied and how it impacts like healthcare and the future of humanity. I have a question about the last experiment, the last work that you mentioned when you showed that the biggest factor impact in the retention of these nutrients was climate change control, right? So in terms of impact, I completely agree with you, but how about the economic expense in dealing with that?
Yes. Our analysis included no cost, right? It only included impact. And I think also, so cost is one big thing. There's also political realities, right? So yes, the Paris Agreement is certainly a nice idea. I don't know what will happen. And I didn't talk about other things that might be relevant. For example, if you know that the nutrients in your crops are going down, maybe you could do genetic engineering and make new crops. Maybe people would substitute other things in their diet. So lots of open questions there, and I think the cost of doing so, any of these things is really a big question.
¿Hay alguna otra pregunta?
Thank you very much for the presentation. It was fantastic. I just want to ask maybe a little bit different question. Could you please tell us more about this relationship between the university and the implications, the impacts that you mentioned here? Because you show us incredibly good papers, and at the same time, you are confronting the most important problems of our life at the moment. So I really would like you to mention something about this philosophy, general approach that you have in Stanford about this conjunction between academic work and social impact work. That's it. More comments, of course.
So is the question about how to have it?
Yeah, exactly. How do you handle that? How do you manage to do that?
It really depends on the project. So the project about predicting COVID was working with the Israel Ministry of Health. And so, in COVID, people wanted answers. So that, but I think some of the others you publish in a journal. Oh, so I'll tell you a good one. The one about the drug abuse and the opioid addiction. We published that in a journal, and it turned out the Assistant Secretary for Health in the United States read it. And he literally called me up and said, nobody else has modeled the effectiveness of policies to control the U.S. opioid epidemic. I would like to have a meeting in Washington, D.C., and I want you to come. And literally, this was a spreadsheet model. It was a nice spreadsheet model, but it was a spreadsheet model because we were the first people to do this. And it was published in American Journal of Public Health, which I guess he had seen. But his job as Assistant Secretary was to think about what to do about the opioid epidemic. So I think in that case, it was because we made the first model and it was kind of reasonable. So sometimes we just do it and hope. And that was an example of good. I think on the climate change, for example, we published the paper, it's been cited, and who knows, that's a very complex problem. Right. So to a greater or lesser extent, our work has impact. Sometimes you're working with people, sometimes people see your work, and sometimes, well, change has not yet come. So we don't always have a plan, we just do it and hope for the best.
Thank you very much.
¿Alguna otra pregunta?
Thanks for the explanations. Just going back to the Israeli example, because it's a clear explanation how really the modeling works in a real problem. But that to have the possibility to take real measures to control the pandemic, you need an early warning, an early result of the modeling prior to implement actions.
Yes.
So your modeling, how early allows to have the warning, the health system to be able to do reactions?
Day by day. We roll the model forward day by day. So every day you can predict the next 7 days in every region of Israel.
So you have 7 days in advance prior to really happens. the results?
No, I mean, today, I'll tell you what's going to happen tomorrow. I'll predict what will happen tomorrow.
Okay.
Yes, and so every day they can decide.
So
And they did it on a weekly
So you have a 24 hours prediction.
Yeah.
And how sensitive are the actions you can actually adopt
Yeah.
to have a result to change that reaction?
I would say it was like once a week, probably. About once a week, the ministry would come up with, no school in this district, or, no grocery shopping.
And you could really see those effects in your modeling and the real data later.
We did not.
Has a feedback in the
We
process.
did not get feedback later. We just gave them the tool. Yeah. So, and I will say the data is kind of confounded because up and down, and there were lockdowns along the way. So our idea was just see what happens and then predict.
And you have kind of dynamic modeling to be improving the process on the way.
No, it's just sort of a rolling horizon. So you just say, so we didn't change our model. No, we didn't. You could though. But then COVID started becoming less important. So,
Just to be thinking in other applications.
Yeah. Oh, I think there are lots of things you could do with such a model to improve it, right? I fully agree. If it was a real model, you need to have it be dynamic. Some of my colleagues at Stanford worked with the state of California on dynamic models, where, for each county in California, we looked at who's getting COVID vaccines, who's getting tested. And those were dynamic models that learned from the past and adjusted. So, yes.
Thank you.
Good point.
Thank you, and thank you for such a great presentation. My question will be a little more technical, that's okay. So, for your research on COVID-19 outbreak prediction, you have really good results in trying to predict the next outbreak and the number of new cases, but the research depends on a lot of that data. You need a lot of data for that predictions. Did you compare in any part of your work with traditional models or like compartmental models, for example, in order to see the beneficials of this kind of model and this amount of data is comparable with using other kind of models?
We did think about that and decided that it was just so much work just to get this data going that we didn't, but we definitely thought about having a transmission model. But the beauty of what we did, it's an agnostic model. It just says, you had this many COVID cases, you had this many people moving around, here's what's going to happen. So it kind of worked pretty well, so we just stopped. But we did think about compartmental model, I guess.
Exactly.
Thank you very much for your presentation. It's incredible. And my question is there a way to control the zombie drugs of fentanyl consumption with machine learning or EA in medication?
So the question was, is there a way to control fentanyl use with machine learning? That's such a good question. I don't know. I recently was thinking that we might be able to understand networks of drug users, right? We could use machine learning to know who's getting drugs from whom, who's sharing with whom, and then that could help you understand who's bringing the fentanyl and how can we stop it. So you can think about interdiction, stopping fentanyl. I don't know, but I like the idea. Machine learning to stop people using fentanyl. Yes.
Thanks. Thanks.
Thanks again, Margaret, for sharing your expertise with us. It was an amazing talk. Now we have a break to get a cup of coffee.